This is the summary of anti-neoplastics or anti-cancer drug, part 1. There will be a lot of drugs in the first aid, but these are the most commonly asked board questions and most commonly used in the clinics. Okay, so first two drugs are under anti-cancer antibiotics. First drugs are from the class anthracyclines, and the second drug in the class non-anthracyclines. So rubicins, you're supposed to know doxorubicin, daunorubicin, idarubicin and epirubicin. Idarubicin is an oral drug and epirubicin is as less toxic. Okay, so there are three major questions commonly asked for board. First one, mechanism of action. Second one, adverse effect. And the third one, the rescue agent dextrosane. Okay, let's look at it. Rubicin's mechanism of action. Okay, your job is to distinguish rubicin from bleomycin, cyclophosphamide, Topotecan, because these all are breaking the DNA of cancer cells. But your job is to distinguish how they break, right? What is the real mechanism? So doxorubicin intercalate DNA. That means they are very thin molecule. They can intercalate between, they can slip in between the nucleotides so that the DNA replication will be blocked. That is the mechanism of doxorubicin, intercalation of DNA. But there is a secondary mechanism which is important for its adverse effect. That is, because of that, it causes cardiotoxicity. That mechanism is the inhibition of Topo 2 isomerase. But the major mechanism of doxorubicin is, or all the rubicin drugs are, intercalation of DNA. So that's a major point to remember. Okay. Then the adverse effects. To talk about adverse effect, remember the metabolite of doxorubicin is called doxorubicinol. That is a major component causing this cardiotoxicity. So what happened is, this doxorubicin in the heart actually cause intercalation of DNA like other cells. But in addition to that, in heart we have topo 2 beta. It's actually present in the quiescent cells, not unlike in the proliferating cell. Proliferating cells have topo 2 alpha, but that is a minute details. Okay, but just understand, topo 2 beta is rich in quiescent cells like heart cells. There, that is the reason this doxorubicin can easily bind to topo 2 beta. Therefore, it can cause an additional breakage of DNA. That means, in addition to the normal intercalation of DNA in heart muscles, doxorubicin cause topo 2 beta inhibition. Therefore, heart cardiomyocytes will be dying, and which will be replaced by fibrous tissue, by fibroblast. That is the irreversible adverse effect. That is why board really like to ask that question. And one more point, this is a dose limiting toxicity. Okay, cumulative dose limiting toxicity. It is irreversible, but luckily we have a rescue agent or antidote. So dextrosane we can use. But one more adverse effect I want you to remember. There are two. Bone marrow toxicity is there, but extravasation. So extravasation means this can damage the once it is given as IV, it the drug can leak out from the blood vessels and damage outside the blood vessel. That is called extravasation. These are vesicant extravasation. So this drug is actually DNA binding extravasation causing agent. That means this can bind in the DNA of the normal cells and cause damage, and this broken particles will be picked up along with the drug. It will be picked up the normal adjacent cells so that it can cause continuous damage. Anyway, understand, cardiotoxicity is the major adverse effect of doxorubicin. Mechanism of action is intercalation of DNA. So dextrosane is the rescue agent for both cardiotoxicity and extravasation. That is an important point to remember. Okay, so next drug is bleomycin. Bleomycin has different mechanism of DNA toxicity. So bleomycin actually cause the DNA fragmentation and thus kill cancer cell. This is a bone marrow saving cell or marrow sparing drug. That is the reason, even though this has an irreversible adverse effect, we are commonly using this drug. Bleomycin is less emetogenic also, and this drug actually has a irreversible adverse effect. Reason, bleomycin hydrolase is an enzyme which is supposed to eliminate the drug from the cells, but bleomycin hydrolase is very least in our keratinocytes and pneumocyte 1 cells or lung cells. Therefore, in lungs and skin, this drug cause adverse effects. Especially in the lungs, it causes irreversible adverse effect. That is called pulmonary toxicity or pulmonary fibrosis. Bleomycin major adverse effect is irreversible pulmonary fibrosis. What happens is, when bleomycin kills this pneumocyte 1 cells, our fibroblasts going to replace those cells with a fibrous tissue. Therefore, it is a dose limiting toxicity. Okay, and dermal toxicity can cause flagellar hyperpigmentation. Bleomycin, it is a bone marrow saving drug, but it can cause irreversible adverse effect in lungs. Okay, so these two drugs are most commonly asked board question. And the next group of drugs, these are anti-cancer antimetabolites. There are three categories there, but at least I want you to remember these two. These are the most commonly asked because there is a rescue agent which is similar agent we are using with these drugs, but it has two different mechanism of action. So that's the reason. Before that, I forgot to mention here, I put it none because bleomycin doesn't have any rescue agent, unfortunately. That is another thing. It is a reversible adverse effect, but we cannot fix it. Okay. So methotrexate is an anti-folate agent. Okay. Anti-folate antimetabolite, but pyrimidine antimetabolite is 5-FU or 5-fluorouracil, but purine antimetabolite for mercaptopurine, it's another drug. You can refer that later. But these two drugs, let's talk about it. Methotrexate is you have to learn mechanism of action. This is an enzyme dihydrofolate reductase inhibitor. So in human cells, it's actually break the DNA or inhibit the DNA synthesis, both these antimetabolites, right? We are going to give a fake metabolite so that the cancer cells going to pick it up like very fast, because cancer cells divide very fast, so they pick up the methotrexate very fast, and they're going to bind into DHFR so that the cancer cells going to die. But after 24 hours, we need to rescue our normal cells, right? Therefore, we will provide a folinic acid that is called leucovorin. Remember, mechanism of action of methotrexate is folic acid inhibitor, right? Folate antimetabolite analog. So it's going to inhibit folic acid in our body. How do they inhibit folic acid? Like a binding. It's actually folate antagonist. Therefore, this is actually a folate antagonist. Therefore, it's going to bind the DHFR enzyme and thus inhibit the cancer cell division. But when we give leucovorin, we can rescue the normal cells. Normal cells are rescued by leucovorin. Okay. Then this leucovorin will be given after 24 hours so that we can rescue the normal cell. Its adverse effect is actually like this is a very small molecule so that it can be eliminated through the urine, but it is insoluble in urine, therefore it can cause crystalluria and severe, sometimes it can cause hepatotoxicity and all. Okay, then but keep in mind, unlike normal treatment for arthritis, etc., methotrexate will be high dose in neoplastic or anti-cancer treatment. The next drug is 5-fluorouracil or 5-FU. This is actually a thymidine-late synthase inhibitor. So remember, in antiviral drug, we were talking about a thymidine kinase inhibitor, right? So that was in viral thymidine kinase, acyclovir. Remember that? So viral thymidine kinase inhibitor is acyclovir, that is we learned it earlier in the previous section. But 5-fluorouracil is a cancer drug which can inhibit human thymidylate synthase enzyme. So therefore we don't produce DNA. But there are other drugs like capecitabine, that is a prodrug of 5-fluorouracil, so that it can actually inhibit the, so prodrug activated inside the cancer cell and activated into 5-FU. That's the same mechanism, it inhibits thymidylate synthase. So what is the significance of leucovorin in 5-fluorouracil? So here we give leucovorin together, but remember in the method with the methotrexate, after 24 hours, once we kill all the cancer cell, we give leucovorin to rescue the normal cells. But in 5-FU, leucovorin is given along with the drug. Reason, 5-FU normally if you given without leucovorin, it will be easily detached from the thymidylate synthase enzyme. Once 5-FU bind on the thymidylate synthase, leucovorin will bind on that, because leucovorin is a larger molecule, so that 5-FU will be bound to the enzyme for longer time, so that the killing of the cell will be like for longer time, the drug will work. That is why we will make sure the cancer cells are killed. That's why. So the efficacy of 5-FU is increased by leucovorin. Okay. So, oh, and this is, I have to do something here. So here it is. Okay, this is mess now. Didn't get time to correct that. Okay, so I don't have time to re-record, that's why I'm going to post the same. Okay, so the next section is alkylating agents. Alkylating agents, you have to know the mechanism of action. Alkylating agent also targeting the DNA of the cancer cell, but this will alkylate DNA. Alkylation is a reaction which chop the DNA very fast. These drugs work so fast. So cyclophosphamide, this is the modified drug from Mechlorethamine. These are nitrogen mustards, very fast acting drugs. Okay, Mechlorethamine was the oldest drug, but cyclophosphamide is a new drug. This cyclophosphamide is a prodrug, that's why we don't have extravasation with this drug, because once the body activate this drug, there is no, it's not going to cause extravasation. That's a point I would like you to remember. But what is the major things to remember with a cyclophosphamide? This drug is metabolized by aldehyde dehydrogenase enzyme. But keep in mind, this drug can cause, most commonly asked question is 3 points. Okay, cyclophosphamide mechanism of action, alkylation of DNA. Then cyclophosphamide causes an adverse effect that is called hemorrhagic cystitis or blood in the urine. The patient will pee blood, or blood will be in the urine. How is it happening? It is not going to damage kidney. That is the point to remember. This is not damaging the kidney, but it is damaging the urinary bladder. Okay, lining of the urinary bladder. One more time. Cyclophosphamide, after metabolism, produce an enzyme called, sorry, uh, um, uh, produce a metabolite called acrolein. This acrolein going to chop all the um, cells in the lining of the urinary bladder, that will be transitional epithelium, and also the muscle and blood vessel. Therefore blood will be appearing there. But to prevent acrolein toxicity, mesna has to be pre-treated. If you don't give mesna with a cyclophosphamide, the patient can produce acrolein, and it's going to damage the urinary bladder. What mesna do is, mesna going to bind the acrolein. Keep in mind, this will eliminate from the kidney without any problem. Acrolein will not damage the kidney. It will be freely filtered through the kidney into the urinary bladder. Therefore, acrolein can damage only the urinary bladder. Remember the condition called hemorrhagic cystitis, and mesna is the rescue agent. Okay, rescue agent for hemorrhagic cystitis. And acrolein also cause alopecia in patient. Okay, and this is also an emetogenic drug. Mechlorethamine is an emetogenic, highly emetogenic drug. Like I said, it is a nitrogen mustard, very unstable drug. Only in the severe cases we give this drug to the patient. About 90% nausea and vomiting is reported, but this is actually, out of all the drugs, cancer drug, this is the most vesicant drug. Vesicant extravasation is most common in this drug because highly unstable. And this drug has a rescue agent called sodium thiosulfate. I don't want you to memorize that because that's not body, don't ask those questions. But there is a rescue agent for this also. Then the next drug is Busulfan. Busulfan, it is not nowadays using for as a cancer drug, but we are using this for bone marrow transplantation. Reason, Busulfan is causing 100% bone marrow suppression. Why I put this drug here is, this is actually an alkylating agent, typical alkylating agent. Similar to Bleomycin, Busulfan cause pulmonary fibrosis. This pulmonary fibrosis is commonly called Busulfan lung. But it differs from Bleomycin by mechanism of action, and also Bleomycin was a bone marrow saving drug, but Busulfan is a bone marrow suppressing drug. That is the difference. I want you to remember that clearly. Okay. The next next Carmustine. Let's look at that also. Carmustine also a typical alkylating agent. Why I'm going to distinguish these two drugs, because these are atypical alkylating agent, also called platinum analog. Okay, let's finish this Carmustine. Carmustine is the drug which pass blood-brain barrier. Therefore, it is very effective to treat brain tumor. And also, this can be very effectively used as wafer implant. That is a unique method to treat brain tumor. So, board like to ask that. So, remember mechanism of action, because it is a alkylating agent. Okay, same alkylation. So, the next section is cisplatin and oxaliplatin. These are called atypical alkylating agent. So what is the difference? I want you to remember so that you can distinguish these drugs. So cyclophosphamide, mechlorethamine, Busulfan and Carmustine cause alkylation by forming, cross-linking the DNA. That means between two DNA strands there will be cross-linking. It will be irreversible. So it's going to be completely, it's like covalent binding of this drug between these two strands, so that the DNA cannot separate. Also Cancer cells cannot multiply. Cancer cells will die. But cisplatin and oxaliplatin, generally they do cross-linking between intrastrand. That's the difference if you wanted to remember. But there are other differences, but just remember these are all alkylating agent. That's all board like to ask like that, okay? Then cisplatin and oxaliplatin, out of these two, cisplatin is the most important drug. Most commonly asked board question also. Why? This can cause irreversible nephrotoxicity. Okay, stop right there. These drugs in this section is alkylating agent. But cyclophosphamide cause blood in the urine because hemorrhagic cystitis damaging the urinary bladder. But cisplatin damage our nephrons. That is why cisplatin is a, you're supposed to distinguish those two drugs, and it's commonly asked question also. Cisplatin can damage our nephron and cause irreversible nephrotoxicity, and also this can damage our cochlear cells and cause ototoxicity. Ototoxicity and nephrotoxicity are common in cisplatin. So stop right there. Before we finish, let's go back to antibiotics. We learned two drugs, separate drugs, causing ototoxicity and nephrotoxicity. Vancomycin, those are cell wall synthesis inhibitors. Those are glycopeptides. They can cause irreversible ototoxicity and nephrotoxicity. Similarly, another class of drugs, that is a protein synthesis inhibitor, that class is aminoglycosides. They can cause irreversible ototoxicity and reversible nephrotoxicity. But cisplatin cause the same thing. These are irreversible nephrotoxicity and ototoxicity. But luckily, to protect the kidney, we have amifostine, that is an agent which is a rescue agent which can protect or save the kidney. That is why cisplatin, this drug, has one protective agent, amifostine, but ototoxicity is irreversible. Remember that, okay? Both are irreversible adverse effect, but amifostine generally protect from toxicity in the nephron. Slightly ototoxicity also will be alleviated by this drug, okay? This is out of all the cancer drug, cisplatin is the highly emetogenic drug. Most, like 100%, all the patients get like emesis because of this drug, okay? And what else? And next, oxaliplatin, I want you to remember only one point, that will be the cold sensitivity. Of course, I will, there are one more cancer drug summary section. In that section, I will explain again, okay? Or in other second year students needed those topics in other lectures, so we will discuss that again. So Vincristine, Vinblastine. Okay, so next 8 drugs are plant alkaloids. So plant alkaloids are classified into 2 major division, okay? First one, Vincristine, Vinblastine, Paclitaxel, Docetaxel. These 4 drugs have same general mechanism of action. They inhibit microtubule. These are called microtubule inhibitors or mitotic inhibitors. That is the mechanism of action. If you wanted to distinguish, the first 2 drugs are Vinca alkaloids. They will be inhibiting the microtubule formation or mitotic spindle formation. But taxols or taxanes or Paclitaxel and Docetaxel, these 2 drugs inhibit microtubule dissociation. Okay, these are 2 different stages of mitotic spindle formation. That's all you need to remember. So all these 4 drugs have same mechanism of action, mitotic inhibitors. But Vincristine and Vinblastine, Vinca alkaloids, inhibit microtubule formation during the mitotic spindle formation, right? They inhibit mitotic spindle formation, but mitotic spindle dissociation will be inhibited by taxanes. Those are Paclitaxel and Docetaxel. Let's look at the drugs um, mechanism of action you already understood. What is the importance of these drugs? Out of this, I think Paclitaxel and Docetaxel generally they ask for only mechanism of action, but I seen questions, other questions for adverse effects questions for Vincristine and Vinblastine. Okay, so Vincristine is a bone marrow saving drug. How I remember is Christ the Savior. So Vincristine save bone marrow. Why I am saying that here? Because just opposite is Vinblastine. They blast the bone marrow. That is an adverse effect of Vinblastine. Vinblastine damaged the bone marrow. Vincristine, Christ the Savior, saved the bone marrow. Remember one more drug we discussed, Bleomycin, that will save the bone marrow. I missed to tell you one thing. Cisplatin also a bone marrow saving drug. That is the reason, even if it has an irreversible adverse effect, we commonly used cisplatin because cisplatin is a bone marrow saving drug. Only 3 bone marrow saving drugs in this cancer drug, this page: Bleomycin, cisplatin, and Vincristine. Okay, let's move on. Vincristine also cause Vincristine adverse effect. I want you to distinguish these two drugs with the adverse effects. Vincristine has an adverse effect, that is peripheral neuropathy. How are you going to remember? Paclitaxel also has adverse effect peripheral neuropathy. Even Docetaxel has, but little bit less. Paclitaxel and Vincristine has peripheral neuropathy. How are you going to remember? This is a very small molecule, but still it cannot pass blood-brain barrier. But instead, it can pick up by our peripheral nerve endings, microtubules of our nerve endings. That's the reason we get peripheral neuropathy. Hope it is clear for you, because in the peripheral neurons it can cause microtubule. It's bind on the microtubules, and therefore it causes peripheral neuropathy. Vincristine and Paclitaxel. When they created Vinblastine, then the scientists created, the structure is different. That's the reason that has less peripheral neuropathy, but more or like severe bone marrow toxicity or bone marrow suppression. Okay, a lot. The next one, so the next 4 drugs are called Topoisomerase inhibitors. How are you going to remember? First 2 drugs are Topo1 inhibitors. It's called Topo1 inhibitor. And the second section, these are derived from the plant. These are called camphothecins. And the third and fourth drugs are called podophyllotexin. But just study Topo1 inhibitors. I remember like this, Topo1. But this drug name is Irinotecan. So these are most commonly asked questions. Out of 4 drugs, Irinotecan is the most commonly asked board question. So let's look at it. Topotecan and Irinotecan are Topo1 inhibitors, easy to understand. Etoposide and Teniposide is Topo2 inhibitors. I'll tell you. Topotecan, nothing much to remember. This drug actually causes a lot of dose limiting bone marrow suppression or myelosuppression. That is the one thing to remember. Other than that, I wanted to remember just mechanism of action for this drug for the board question. But Irinotecan, I want you to study in details, like the drugs like a cyclophosphamide, cisplatin, Doxorubicin, Bleomycin, these drugs. Similarly, Irinotecan is supposed to learn everything. So let me tell you the story. Why is it? It's very effective to treat different cancers, but it has some severe adverse effect that is unique also. Irinotecan cause diarrhea. It's like you can connect like I ran to the can. Anyway, whichever way, diarrhea. Out of all the cancer drug, Irinotecan cause like really severe diarrhea. But it is because of very unique metabolite called SN38. Okay, one more time. Irinotecan is a prodrug, but it is also active. It can kill cancer cells. But once it gets into our body, liver metabolize irinotecan into an active agent called SN38, which can damage our digestive system or GI tract. Remember that way. And this can cause diarrhea. Okay, but actually, what happens is it can affect your nerve endings and in the lining of the cells. Okay, so anyway, so irinotecan's metabolite SN38 in the normal cells, it's going to, after some time, it's going to be eliminated by UGT1A1 enzyme. That is the reason if a patient doesn't have UGT1A1 activation, the patient's diarrhea will be very severe. Therefore, before giving irinotecan, you get UGT1A1 test to make sure this toxicity is not there. Anyway, SN38 is metabolized by UGT1A1. Other than that, remember SN38 can cause diarrhea. But there are two types of diarrhea. About 50% patients get acute diarrhea, and about more than 80 or a lot of patients developed delayed diarrhea. Okay, so remember, anyway, irinotecan SN38 is the metabolite causing diarrhea. Remember other metabolite we were talking about, entirely different drug. Cyclophosphamide produce a metabolite acrolein cause hemorrhagic cystitis. Okay, so it's a different story. Okay, etoposide and teniposide, not much. I want you to remember mechanism of action, Topo2 inhibitors. Easy to remember because they make a double DNA strand break. This can integrate into the cell, and after even the patient is cured, they can get secondary carcinoma. Maybe after 30-40 years, patients can get secondary carcinoma with these two drugs. Remember that double strand breaking, and somehow I wanted to connect. Okay, the next, all these next group of drugs are targeted therapy. Out of that, most commonly asked board question is trastuzumab. But I'm going to explain these drugs also, because in first aid and for the medical students it is so important to learn that. Okay, trastuzumab, what are the major things to remember? Okay, you need mechanism of action, adverse effect, and drug interaction, kind of another point. Okay, let's look at it. Trastuzumab is actually a HER2 positive specific antibody. Okay, that means if a patient has cancer which is positive to HER2, okay, HER2 means human it is a growth factor, epidermal receptor factor. So it's a growth factor. So keep in mind, about 70% of cancer, breast cancer is ER positive. We will talk about in the next section of anti-cancer drugs. But about 20% of breast cancer is HER2 positive. That means those cells depending on HER2 growth factor to multiply. Similarly, some about 10 to 15 to 20% of gastric cancer also HER2 positive. That means if a patient coming with a HER2 positive cancers, we can give specific targeted therapy, trastuzumab, this antibody going to bind specifically to that cell. Very good. We can kill the cancer. Perfect. But the problem is this can produce, okay, most common adverse effect is fatigue, but it can cause cardiotoxicity. Therefore, you should not add this with other cardiotoxic drugs. We learned rubicins, right? Red devils. This doxorubicin should not combine. But still you have to understand, if there is no option, there are very low dose combination drugs are available. You will learn in clinics later. But keep in mind, trastuzumab has a toxicity, cardiotoxicity. But out of all the drugs, major cardiotoxic agent is doxorubicin. Therefore, please avoid adding that with the trastuzumab. Okay, maybe you can get that board question. Then trastuzumab the cells become very tricky. Once this going to bind on the cell membrane, it can engulf into the cell and destroy. To prevent that, scientists actually used a toxin into the trastuzumab, that is called trastuzumab emtansine. This is going to be trastuzumab resistance. If a patient develop, you can give trastuzumab emtansine. But the problem is this drug is actually like a more expensive. Anyway, pertuzumab, same mechanism. Remember, pertuzumab is why I mentioned this one is I wanted to distinguish this drug with the pembrolizumab. Pertuzumab inhibit HER2. It's going to bind HER2 receptors and inhibit HER2 positive cancers. This is going to bind two sites. That is the difference. So if any cancer is resistant to trastuzumab, you can give pertuzumab, little more effective agent. But next drugs, pembrolizumab. Pembrolizumab is a programmed cell death protein 1 inhibitor. PD1 receptor of T lymphocyte is inhibited by bind to PD1 receptor of T lymphocyte. That is, it's commonly called PD1 inhibitor. Okay, pembrolizumab we will you usually learn in second year medical school class. Pembrolizumab is actually very effective agent, PD1 receptor binding drug. Okay, then bevacizumab, not much, there is GI side effect, but that's not going to ask. Only the thing is pembrolizumab I wanted to remember mechanism of action. Bevacizumab, same thing. All these drugs, mechanism of action is super important. Bevacizumab, I wanted to learn mechanism of action and the adverse effect. I will tell you the reason. Bevacizumab is a VEGF growth factor inhibitor. Okay, vascular endothelial growth factor inhibitor. Easy to remember. This actually inhibit tumor vascularization. VA, vascularization. So bevacizumab inhibit vascularization. That's why tumor will be shrunk. But the problem is, if a patient develop wound or something, they're going to get wound healing delayed. That's a one adverse effect. Patients' wound healing complications will be reported in bevacizumab. Therefore, I want you to remember adverse effect and mechanism of action. Then natalizumab, I will explain that in other lectures. That's why I don't want to explain, but still understand. Rituximab is, what is it, CD20 binding. Natalizumab alpha 4 integrase. So we will discuss that later. But let's look at the last two drugs and finish it. Okay. This targeted therapy is actually tyrosine kinase inhibitor, imatinib. See, nib, mib, clip. These are specific drugs. These are just targeting specific cells, right? So if any cancer positive to tyrosine kinase, we will treat with the nib drugs, imatinib. Imatinib. So these drugs are actually, there are different nib drugs. One, at least study one drug. So mechanism of action is the commonly asked question, but study adverse effects also if you like, because fluid retention is common with these drugs. Then the next mechanism of action is bortezomib. Bortezomib is a boron containing drug. This can be used for multiple myeloma also. This drug actually causing proteasome inhibition, right? So this is going to break the 26 yes, proteasome and inhibits its activity. That means it's going to damage the paraproteins in the cell, damage the trash can of the cells and accumulate. That means trash can means like a its metabolism is inhibited by this drug. Okay, it's going to cause accumulation of toxic paraproteins. That's how this is going to bortezomib going to work. Okay, it's like a zombie, right? It's going to accumulate a lot of toxin. Then palbociclib mechanism of action. This is actually a CDK4/6 dependent tumor targeting drug. That means this inhibits CDK4 and CDK6. It's G1 cell cycle arrest is the real mechanism. Okay, cell cycle specific drug. Okay, I think this is it for this section and first part of anti-neoplastic. Then I will make another video for the breast cancer drug and all those different types of cancer drugs. Okay, thank you. Bye.